You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola for theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 26, 2024. This week, health and income, high blood pressure in the hospital, and more on subclinical AF and when to anticoagulate. The first topic today is health and income. It has become fashionable these days to use the phrase, quote, social determinants of health. That is, people with challenging social situations have worse health outcomes than those with better social situations. For instance, when I visited Oslo or Copenhagen, it was clear to me that the gaps between the poor and rich are smaller than in U.S. cities. I've spent time volunteering here in a city clinic and it shocks me how little these patients gain from an electrophysiologist. EP cannot help them because their problem is having enough money or shelter or family support, not any complicated treatment of arrhythmias. So for sure, there is certainty in knowing that poverty and income is an important factor in determining health. Yet, how best to help people in this situation is very much uncertain, and there are two big approaches to uncertainty. The first approach is to just let smart people decree a policy, say school closure during the pandemic. Or the second approach, randomize patients to different policies and then measure outcomes. This week, two major clinical trials were published regarding approaches to poverty and health. JAMA published the first one, and Yale nephrologist and Medscape contributor F. Perry Wilson covered it. The title of the study in JAMA was The Effective Cash Benefits on Health Utilization and Health, a Randomized Study. The first author, Sumit Agarwal, along with his colleagues at Harvard, led a clever RCT in which 2,800 people were randomized. They did this in a small town in Massachusetts. People in a low-income community were randomly assigned via a lottery to receive a cash benefit of $400 per month for 9 months. One group of about 1,700 people got the benefit and 1,100 control people did not. The primary outcome was emergency department visits. The mean age of these people were young at 45 years. More than 70% were first language Spanish. The mean family income was just $16,000 per year. Most of the people were women, and the main outcome was positive. ED visits in the cash benefit group was 217 per 1,000 person years versus 317 per 1,000 person years, which met statistical significance, though barely. This also led to fewer hospital admissions. There were no differences in outpatient visits, visits to primary care, or outpatient behavioral health. Visits to specialty care were slightly higher in the active arm. Importantly, however, there were no differences in health outcome measures such as COVID-19 vaccines, blood pressure, BMI, hemoglobin A1C, or cholesterol levels. The authors concluded that the study results suggest that policies that seek to alleviate poverty by providing income support may have important benefits for health and access to care. Dr. F. Perry Wilson, my colleague at Medscape, also lauded the results, saying that the truth is you probably have causality in both directions. Making people healthier will make them less poor, and, as this study suggests, making them less poor may make them healthier. Before I say anything and comment on this, let me tell you about the second study, which I think is much more robust, albeit it's not published in a medical journal, it's published in the economics realm. The title of this study is Does Income Affect Health? Evidence from a randomized controlled trial of a guaranteed income. The first author is Sarah Miller, and she's at the University of Michigan in the business school. The study was called the Open Research Unconditional Income Study, or ORUS study. The study was published in the NBER, and it's a working paper. Now, the first thing to say about econ reports of RCTs is that they don't have a word or reference limit, and the thing is massive. I mean, it's the size of an entire issue of the New England Journal of Medicine. So my report will make it a lot shorter than it is. The basic question of these researchers was to make a causal estimate between giving $1,000 per month versus $50 per month to low-income adults in 2 U.S. cities. The randomization was 1-to-2, so it was 1,000 versus 2,000 adults. The study was carried on for 3 years, not 9 months. Now, right there, notice the differences between the Boston experiment, which was just $400 and just 9 months. The main findings of this big paper was that the cash transfer resulted in large but short-lived improvements in stress and food security. It resulted in greater use of hospital and emergency department care, and increased medical spending of about $20 per month in the treatment relative to the control group. These findings suggest that the use of other office-based care, particularly dental care, may have increased as a result of the transfer. But they found no effect of the transfer across several measures of physical health as captured by multiple well-validated survey measures and biomarkers derived from blood draws. Quote, "We can rule out even very small improvements in physical health and the effect that would be implied by the cross-sectional correlation between income and health lies well outside our confidence intervals," end quote. They also write that they can find that the transfer did not improve mental health after the first year, and by year 2, they can reject very small improvements. They write that they also find precise null effects on self-reported access to health care, physical activity, sleep, and several other measures related to preventive care and health behaviors. And they finally concluded that more targeted interventions may be more effective at reducing health inequity between high and low-income people. Okay, so my comments. This is a real interesting topic. I've written on the topic before in 2019, and I'll link to this piece. I reviewed an interesting book co-authored by the George Mason economist Robin Hanson entitled The Elephant in the Brain. Hanson has long held that empirical data don't really support the notion that more healthcare or more healthcare access leads to better health. It's a provocative concept, and I'm drawn to it because it requires us, the medical profession, to be a lot more humble about what we contribute to society. Back in March of 2023, March 17th specifically, I discussed many of the empirical studies suggesting that providing more health care to people does not lead to better health. There was the RAND, Oregon, and India health insurance studies, which were all essentially null for providing more health insurance. There have also been 2 trials looking at eliminating co-payments or even free meds for cardiovascular health. The MI-Free trial, which I'll link to, published in New England Journal of Medicine, famously found that free statins, beta blockers, ACE, and ARBs after MI did not change outcomes. And the group of Dr. Rishi Wadera at Harvard Medical School even found that in the Medicaid expansion states, this led to no significant differences in the treatment of cardiovascular risk factors. My take home, therefore, is that cracking the problem of inequalities in health in our population is super complex. Direct cash transfers did not seem to do much. Even substantial boosts of income, like in the case of the ORUS study that I just talked about, had no significant effects. The previous RAND, Oregon, and India studies and the slew of cardiac studies like MI-Free paint a very humbling picture. That is, those of us treating patients have the chance to improve the health of the person that we are seeing. But it is a much different matter when it comes to improving the health of populations. This is a far more complex issue, and the empirical data suggest, surprisingly, that it surely requires more than just providing access to care. This is one of the main reasons why I've come to believe that the best policy solutions would be to advocate not for one or another specific policy, but rather a culture of randomization. All right, second topic, let's talk about elevated blood pressure in the hospital. The vast majority of topics covered on TWIC, This Week in Cardiology, stem from studies. This week, I want to speak on the problem of elevated blood pressure in the hospital. JAMA Internal Medicine has published an elegant and short clinical insights paper from Dr. Zachary Jacobs and Timothy Anderson. I'm approaching 3 decades of working in hospitals, and little has changed around the folly of treating elevated blood pressure. I still see patients who have been harmed by overzealous therapy of asymptomatic high blood pressure readings in 2024, even though we talked about this back in the 1990s. The process of harm goes something like this. A nurse on the floor notifies an on-call person about an elevated blood pressure. The on-call person hardly knows the patient and is likely covering 100 or more patients that night. The blood pressure is high, like 180 over 110. So often a drug is given. Many times nothing bad happens, but sometimes that person gets low blood pressure, which may cause a fall or acute kidney injury or even a stroke. Doctors Jacob and Anderson review the evidence, which is mostly observational, but mostly suggest caution rather than aggression in treating elevated blood pressure readings. They offer a very simple 6-step plan for approaching the patient with an elevated blood pressure in the hospital, and I love it, and it's beautiful, and it's short. First, you assess for end organ damage. If you see it, then treat as a hypertensive emergency in the ICU. If you don't see it, move to step 2. Step 2, ensure appropriate blood pressure technique, like the right cuff size, for instance, then remeasure after a period of rest. Step 3, identify and treat factors that may exacerbate blood pressure, such as pain, volume excess, alcohol withdrawal, or even drug intoxication. Pain is the most common thing that I see in my experience. Fourth step, review home and hospital medicines that could worsen blood pressure. Consider stopping these medicines. The classic one is nonsteroidal anti-inflammatory drugs, but also decongestion stimulants and steroids. Step 5, if after these 4 steps the blood pressure is still elevated, then you consider patient-specific factors before deciding to intensify the home blood pressure therapy. Step 5A, factors that argue against intensifying therapy are good baseline control of blood pressure at home, or frailty, or limited life expectancy, or cognitive impairment. Most patients, for instance, do not want medicine intensification in the hospital. Step 5B, you can consider medication increases when there is a patient readiness to make a change, and in selected high-risk patients, you can initiate a guideline concordant blood pressure medicine. Finally, step 6 is also important, and that is to develop a transitional care plan. Whether the choice is to watch the blood pressure and not treat, or to add additional medicines, it is crucial that this patient gets proper follow-up and instruction on taking home blood pressures. Now, my comments. I really love this short piece, and it's an extremely medically conservative approach. This practice, if used, would save many people from potential iatrogenic harm. I would propose that it not only be taught in residencies and fellowships, but also in nursing schools, because some of the tension in treating these numbers and not symptoms stem from worry on the part of nurses. I say kudos to JAMA Internal Medicine and the authors. Please, all of my listeners, help me spread the word on the give peace a chance to inpatient asymptomatic high blood pressure readings. All right, finally, another big topic is short duration subclinical AFib. It's like the topic of our era. Now, once again, we are back to the matter of the subclinical AFib. It's almost an everyday decision for me. 3 hours of AFib, 6 hours of AFib, 30 minutes of AFib in a post-stroke patient, what to do? Well, the ARTESIA investigators have published this week an important post-hoc analysis of their trial of Apixaban versus aspirin for device-detected AFib, and it was based on the CHADS-VAS score. Before I tell you about this subgroup study, which the authors do make strong conclusions from, we need to set out the results of ARTESIA main trial, as well as the fact that there is another similar trial in this space called the NOAA trial, which randomized patients with device-detected AFib to Apixaban or placebo. First, the main results of ARTESIA. 4,000 patients with device-detected AFib. The trial was stopped early for slow enrollment and lower than expected stroke rates. Apixaban reduced the rate of the primary outcome, which was stroke or systemic embolism, by 37%. Hazard ratio 0.63, and the confidence intervals were highly significant at 0.45 to 0.88. But this stroke reduction came at the cost of a 36% increased incidence of major bleeding. This was 1.53 versus 1.12% per year in absolute terms. The hazard ratio was 1.36, and the confidence intervals were also significant at 1.01 to 1.82. The thing was that the absolute stroke reduction was tiny. If you count it per year, it's 0.78 versus 1.24%. Now note that the stroke rate in the control arm was 1.2%, which is way less than the 2.2% rate we like to associate with CHA2DS2-VASc score of 2. And the main results of the NOAA trial were similar. 2,500 patients, Apixaban versus placebo, and Apixaban reduced the primary endpoint of stroke, systemic embolism, and CV death. The trial was stopped early for increased bleeding, and the 19% reduction in the primary endpoint did not reach statistical significance. The bleeding rates were also higher in NOAA, 31% higher in the Apixaban arm. Also true was the absolute stroke rates were low in the placebo arm at 1.1% per 100 patient years. So when you look at the main studies, it's just still not clear whether we should treat device-detected AFib with short duration. Yes, you do get some stroke reduction. It's small in absolute terms, but you also get increased bleeding, also small in absolute terms. Some of the ARTESIA investigators have said, rightly, that stroke is worse than bleeding and we should lean towards anticoagulation, but that is definitely just an opinion. The question now is whether these sub-studies can provide better answers than the main studies. Jack has published the ARTESIA CHA2DS2-VASc sub-study. I've covered it as an abstract, but let's re-review it because it's just an everyday decision and it just came out this week. The ARTESIA investigators broke the subgroups into 3 groups: CHA2DS2-VASc less than 4, CHA2DS2-VASc equal to 4, and CHA2DS2-VASc greater than 4. They had about 1,000 to 1,500 patients in each, so it was pretty equally split. The main finding was that the only group that sustained a significantly lower hazard ratio, it was actually 0.44 for Apixaban over aspirin, was the CHA2DS2-VASc greater than 4 arm. It was 18 versus 38 strokes. This was nearly a 4% absolute risk reduction. They found no significant difference. The Apixaban versus aspirin had basically the same kinds of increases. They were not statistically significant. It was 27% versus 48% higher with Apixaban versus aspirin in relative terms. Apixaban, therefore, seemed to have a heterogeneous treatment effect for stroke reduction, but not bleeding when you looked at CHA2DS2-VASc scores. The authors concluded that 1 in 4 patients in ARTESIA with subclinical AF had a CHA2DS2-VASc score greater than 4 and a stroke systemic embolism risk of 2.2% per year. And for these patients, the benefits of treatment with Apixaban in preventing stroke or systemic embolism are greater than the risks. But the opposite was true for patients with a CHA2DS2-VASc less than 4, and there was a substantial intermediate group, CHA2DS2-VASc equal to 4, in which patient preferences will inform treatment decisions. Now, my comments are this seems to make it easy, right? Just anticoagulate those with CHA2DS2-VASc greater than 4 who have device-detected AFib, but I don't think it is that easy. First, is always the issue that this is a subgroup analysis from a main trial that essentially had no results in that stroke reduction was similar to major bleeding. Second, when you look at the P for interaction of this subgroup, it was not significant. It was close, but not significant. And third, I think most importantly, when considering the ARTESIA investigators' conclusion, there's other data to consider. 2 months ago, the European Heart Journal published a rapid communication from the NOAA authors looking at an Apixaban versus placebo effect based on risk factors. In this sub-study of NOAA, they made 2 groups, CHA2DS2-VASc less than or equal to 4 and CHA2DS2-VASc greater than 4. Now recall that NOAA had 2,500 patients versus 4,000 in ARTESIA. And what they found is that in the CHA2DS2-VASc greater than 4 group, the higher risk group, the hazard ratio for the primary endpoint of stroke, systemic embolism, or cardiovascular deaths of edoxaban versus placebo was 0.88, and the confidence intervals were very wide at 0.55 to 1.41, so it's not significant. And even in this high-risk group, the stroke rates of stroke were low at 1.2 per 100 patient years. In the total population, efficacy and safety outcome rates increased with increasing CHA2DS2-VASc scores without a treatment interaction. So we have sort of conflicting results between ARTESIA and NOAA in terms of these subgroups based on CHA2DS2-VASc, but let me make it even more complicated than that. Another factor influencing the anticoagulation decision, in addition to CHA2DS2-VASc score, is the duration of the episode. And ARTESIA investigator Bill McIntyre has presented an analysis at the European Heart Rhythm Association. I have the slides. I have not yet seen the publication. This looked at stroke risk according to the baseline duration and frequency of AF episodes. This was a surprising analysis. The absolute risk of stroke was about 1%, regardless of whether you had subclinical AF less than 1 hour, 1 to 6 hours, or greater than 6 hours. It did not matter. When they looked at treatment effect, Apixaban versus aspirin did not show any added benefit for the longer duration episodes. Apixaban treatment versus aspirin was also not affected by the frequency of the episodes. So my comments. Despite the ARTESIA CHA2DS2-VASc paper, which suggests that higher risk patients with device-detected AFib should be treated, we have against that declaration, A, it's a subgroup of an essentially non-significant trial. B, the P for interaction was non-significant. C, it's not confirmed in the NOAA trial subgroups. And further analysis of ARTESIA shows that the duration or frequency of the episodes have no bearing on the detection. Bottom line is that despite more than 6,500 patients randomized, we really don't know what to do with device-detected AFib. I think that is because of something that Soren Diedrichsen and I have talked about and written about, and I'll link to our paper that's in Stroke, and that is that device-detected short-duration, often asymptomatic AFib is a different entity than the AFib we diagnosed before we had these devices. It's more ubiquitous, it's lower risk, and treatment is not going to be the same. What is the best approach? We don't yet know, but NOAA and ARTESIA and their sub-studies clearly show that we need a new kind of thinking regarding this condition. I realize this is a moving topic. Different people have different opinions. I'm happy to hear your opinion. Let me know. And as always, if you like this podcast, please take the time, give us a rating, write us a review. If you disagree with something I say, go to the website, write a comment. I learned from these. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.